me.
Welcome to the Senior Rehab Podcast.
The podcast for rehab clinicians that want to better serve older adults.
And now, your host, Dustin Jones.
Hello, friends. This week's short comes from Sian Smale. She wrote an article titled A Review of Red Flags that was posted on Urson Religioso's site, themanualtherapist.com. This blog is a follow-up from the second episode of the Untold Physio Stories podcast, where Urson discusses red flags and a clinical case of cancer. During the podcast, Jason and Urson discuss the keystone red flags for cancer: recent unexplained weight loss, general malaise, unremitting night pain, pain in multiple spinal regions, and night sweats. These 5 points are taught as key features that should alert our attention to a potential sinister pathology, but really they only just begin to scratch the surface in terms of differential diagnosis. This blog aims to expand on the special questions for the cervical, thoracic, and lumbar spine that physical therapists can be including in their subjective examination to draw out more information about unusual pain presentations. Asking special questions is an important component of every patient examination, and generally, red flags are suspected when with the following features. How old were they when the pain began? An age of onset of pain of less than 20 years or more than 55 years. Recent history of violent trauma, dizziness, the presence of 5 Ds and 3 Ns, explained below. Constant progressing, unremitting, and non-mechanical pain, which is not relieved with bed rest. Thoracic spine pain, past history of malignant tumor, prolonged use of corticosteroids and other long-term medications, changes in bone integrity, liver function, and other body systems. Drug abuse, use of immunosuppressants and HIV, risk of infection. Systemically unwell, unexplained weight loss, widespread neurological symptoms, including cauda equina syndrome, structural deformity, fever and night sweats, general health. Do you have any other medical conditions? How is your general health? Investigations. What scans have they had? Changes in bladder or bowel disturbance, particularly urinary retention and fecal incontinence. Cauda equina signs or symptoms of cord compression, numbness over the perineum, loss of control of continence, incontinence. So the list is quite extensive, and it is our responsibility to check these areas when assessing patients with spinal pain. But have you ever wondered why you are asking them or what you should do if the answers come back positive? So what are we looking for? We are looking for the presence of serious pathology. Number 1, constant pain. 2, pain that is not related to movement. 3, presence of severe spasm. 4, morning stiffness lasting more than 30 minutes. 5, presence of severe night pain. 6, presence of night sweats. 7, history of cancer. 8, recent fracture or trauma. We are looking for signs of spinal cord compromise, non-dermatomal symptoms, ataxia during gait and clumsiness with upper extremity tasks, increased reflexes, positive Babinski sign or clonus, non-myotomal muscle weakness, bladder and bowel disturbance, saddle anesthesia, global progressive upper or lower limb weakness. We are looking for signs of nerve root compression, dermatomal pain, paresthesia or anesthesia, decreased reflexes, reduced strength in a myotomal pattern, reproduction of neurological symptoms with spinal movements. We are questioning about the following conditions because they require special consideration for treatment modalities: active infection, active Scheuermann's disease, pregnancy, active diabetes, inflammatory disorders, metabolic and endocrine disorders, with conditions where instability can result from loss of bone and joint integrity, such as rheumatoid arthritis and spondyloarthropathies. We are questioning for the following medications, which also require special consideration for treatment modalities and differential diagnosis: antidepressants, anticoagulants, oral steroids, strong analgesia, muscle relaxants, opiates. Patients with dizziness. Dizziness is the most common complaint associated with vertebrobasilar insufficiency, VBI. When dizziness is present, you should be questioning for 5 Ds and 3 Ns. 5 Ds are dizziness, diplopia, blurred vision or even transient hemianopia, drop attacks, loss of power or consciousness, dysphagia, problem swallowing, dysarthria, problem speaking. 3 N's: nystagmus, nausea or vomiting, and other neurological symptoms. And others we often forget: lightheadedness or fainting, disorientation, unexplained anxiety, disturbances in the ears, tremors, sweating, facial paresthesia, or anesthesia. The case that Urson presented on the podcast was of a lady with unexplained weight loss, multiple regions of spinal pain, poor response to treatment, general malaise, and the outcome for this client was cancer. It fits the typical box, which we all hear about, but not often do you actually experience this case firsthand. It was great to listen to Urson share his experience about the case and how he reacted when he felt things weren't quite right. There definitely is a fine balance between being hypervigilant with referring patients for further investigation and also questioning enough to know you aren't overlooking a more sinister pathology. In my opinion, build these questions into assessment and make a commitment to regularly ask your special questions. Not often do a whole cluster of them come out positive, and when this occurs, it generally warrants a second review. Thanks, Sean. Hit me. Thank you for listening to the Senior Rehab Podcast. If you enjoyed this episode, you should hop on over to seniorrehabproject.com, where you can find more helpful content and how you can join me and many others in the movement that's changing the face of geriatric rehab. I appreciate you, and I'll talk with you next week. But in the meantime, do not forget to stay funky.